case is a cardiovascular toxicology case for Mini-Talk 4, Nervous System and Cardiovascular Toxicology. Before revealing the answers, take 60 to 90 seconds to think through the case on your own. Draw on what you know about the cardiac glycoside mechanism covered in this talk. We'll then go through the answers together. Answer to question 1. The toxin is a cardiac glycoside, specifically oleandrin and nerein from Nerium oleander. Oleander is one of the most commonly planted ornamental shrubs in the southern United States, the Southwest, and warm climates worldwide. It is toxic in all parts: leaves, stems, flowers, bark, and even the water in a vase containing cut oleander. At the cellular level, oleandrin works exactly like digoxin. It binds to and inhibits the sodium-potassium ATPase pump, the sodium-potassium pump on the surface of cardiac myocytes. Under normal circumstances, this pump actively extrudes 3 sodium ions from the cell and brings in 2 potassium ions per cycle, maintaining the electrochemical gradient that allows the cell to repolarize and fire again. When sodium-potassium ATPase is blocked, intracellular sodium rises. Because intracellular sodium is elevated, the sodium-calcium exchanger, which normally extrudes calcium by using the sodium gradient, runs in reverse or at reduced capacity. Intracellular calcium accumulates. Excess intracellular calcium increases myocardial contractility initially, positive inotropy, but at toxic concentrations, this calcium overload destabilizes cardiac membrane potential and generates arrhythmias. The result: bradycardia, AV conduction block, ectopic ventricular rhythms, and in severe cases, ventricular fibrillation. The answer to question 2. The bradycardia and hyperkalemia are directly mechanistically linked, and this is a clinically important concept. Sodium-potassium ATPase is responsible for driving potassium into cells. When this pump is blocked by cardiac glycosides, potassium cannot be efficiently moved into cells. Potassium redistributes out of cells from the intracellular space into the extracellular space and then into the bloodstream. This is a transcellular shift, not a failure of renal potassium excretion. The result is hyperkalemia. Hyperkalemia then independently worsens the cardiac toxicity. Elevated extracellular potassium reduces the resting membrane potential of cardiac cells, making them more excitable, and disrupts normal conduction through the AV node, worsening the bradycardia and AV block. So the ECG and the potassium value are telling you the same story from 2 different angles. The sodium-potassium ATPase pump is failing throughout the cardiac myocytes. These findings together are highly characteristic of cardiac glycoside toxicosis and should increase your diagnostic confidence considerably. Answer to question 3. Emesis at this point? No. Emesis is contraindicated and inappropriate. 2 reasons. First, 2 hours have passed since ingestion. For most toxins, the effective decontamination window for emesis is within 1 to 2 hours. Significant oleandrin has already been absorbed, as evidenced by the severe cardiovascular signs already present. Second, and more importantly, this patient is bradycardic, hypotensive, and hemodynamically compromised. Inducing vomiting in a cardiovascularly unstable patient risks vagal stimulation from retching, which can precipitate further bradycardia, AV block, or even asystole in a patient already on the edge. It also risks aspiration in a mildly obtunded patient. Emesis is contraindicated once significant cardiovascular toxicity is established. Immediate treatment plan. Let's walk through this systematically. 1. IV access. Immediately. 2 sites if possible, given hemodynamic instability. 2. Continuous ECG monitoring. Mandatory. This patient is at risk for progression to complete AV block, ventricular tachycardia, or ventricular fibrillation at any moment. 3. Bradycardia management. Atropine IV as first line for bradycardia due to increased vagal tone from glycoside toxicity. Dose: 0.02 to 0.04 milligrams per kilogram IV. If atropine is insufficient, consider temporary cardiac pacing. 4. Treat the arrhythmia. For ventricular ectopy, lidocaine IV is the initial antiarrhythmic of choice. Phenytoin is sometimes used for glycoside-induced arrhythmias as it improves AV conduction. Avoid class 1A antiarrhythmics, quinidine, procainamide. They can worsen glycoside-induced arrhythmias. 5. Digoxin-specific antibody fragments, FAB. This is the specific antidote. Digoxin FAB fragments bind cardiac glycosides with extremely high affinity, neutralizing them. They are available, DigiFab, DigiBind, and have been used successfully in veterinary patients. Dose calculation is based on estimated amount ingested or serum digoxin level. In a case like this, empirical administration is appropriate even without a confirmed serum level. This is the most impactful single intervention. 6. Manage hyperkalemia. Do not use IV calcium gluconate initially in a cardiac glycoside toxicosis. In most hyperkalemia scenarios, calcium is a first-line treatment. But in cardiac glycoside toxicosis, calcium administration is relatively contraindicated. It can precipitate fatal arrhythmias by further elevating intracellular calcium in already calcium overloaded cells. Instead, sodium bicarbonate and/or dextrose insulin to drive potassium into cells. K-Exalate if potassium remains severely elevated after initial management. 7. IV fluids cautiously to support blood pressure, but careful not to volume overload a heart with potentially compromised contractility. 8. Activated charcoal. Consider via orogastric tube, not via oral administration in a compromised patient. After securing the airway, if clinical status permits, cardiac glycosides have some enterohepatic recirculation. Repeat doses of charcoal may reduce ongoing absorption. 9. Serial ECG, electrolytes, and clinical monitoring every 30 to 60 minutes. Prognosis depends heavily on how quickly FAB fragments can be obtained and administered. The key teaching points from this case. Oleander is a true cardiovascular emergency with a narrow time to death window. Hyperkalemia in a cardiac glycoside toxicosis is mechanistically linked to pump failure, not renal disease. Calcium gluconate is relatively contraindicated in glycoside toxicosis, the opposite of most hyperkalemia. Digoxin FAB is the specific antidote. Know it exists and know to get it fast. This case illustrates why ECG monitoring is non-negotiable in cardiovascular toxicosis. This slide is for your reference and reinforces the key learnings from our case study. I hope you join me for our next mini talk. Thanks.